Thank you, Mr. Chairman, dear colleagues. Well, these are my thinkings about the topic I have to develop in the next minutes, talking about dementia, some review of basic concepts on recurrent urinary tract infections and the old patients, and about the treatment. So what about the dementia? If you put these words in Google, you find nearly more than 3 million of results. So there is a lot of interest in these recurrent urinary tract infections in the elderly. And if we look at the urinary tract infections in general, we have to think that almost half of women will experience some UTI during her life. And if we look at these numbers, almost 10% will have a second urinary tract infection long life. Probably 3% will experience recurrent urinary tract infection, and nearly 2% of them, these recurrent urinary tract infections will be frequent. So this is a problem. But if we look at the infections at the hospital, nearly 20% of the septicemia came from urinary tract infections, with a mortality of 10%. So we have to think about this problem. And we look at these three very happy old guys. Well, when they get infection, they are not so happy because it has a very high impact on morbidity and in his functional decline, and of course in the frailty, in the concept of frailty. And moreover, even 1/3 of them will die about any kind of infection because older people has an increased risk of bacterial infection. And UTI is the commonest bacterial infection and is the commonest cause of sepsis. So this is the problem, but we, thanks to God, we have antimicrobial products. And we can fight and win the war, but really, finally, we'll win the war or not? Because there is an increasing resistance nowadays. So it's an emerging threat, especially in nursing homes. So even 75% of those who are admitted in a nursing home will receive an antibiotic treatment in the next 6 months. And half of them, the treatment is completely unnecessary. So this is the panorama in Europe. We can see that there are countries in green that have a very low resistance to antimicrobials, but in the worst part, more red, there are some countries that there is a lot of resistance. Spain is not very good, as you can see in this map that shows resistance of Escherichia coli to quinolones. So let's talk about some basic concepts. First, we know that urine is not sterile. Probably many of our colleagues from other specialties should know this point because there is a microbiota that is growing the importance of and understanding the defenses. Because if the older patient has a good microbiota, probably will have better defenses to new microorganisms. Of course, bacteriuria is another concept. We know this concept of asymptomatic bacteriuria. But if we look at the different parts of the risk factors for bacteriuria, most of the older people has these factors. So think about this point. And as high as 6 to 16% of women, older women, have asymptomatic bacteriuria. And even half of them in nursing homes. These figures are half in men, but they are so high. And if we look at another concept of the classifications of the different infections, complicated urinary tract infections are very common in older people, as we know, as we talk about this point later. This is the concept of recurrent urinary tract infection, at least 3 per year or more, or at least 2 per 6 months or more. And the infection mechanism, there are many factors that we'll review in the older patient, but one of the most important is that many of the microorganisms invade the cells, the urothelium cells, and afterwards, during the desquamation of these cells, there is another wave of new microorganisms that can lead to an urinary tract infection. And of course, many of our older patients have problems of bladder obstruction or problems of underactive bladder, so many of them has to undergo catheterization, so permanent catheter. And we know that it is very common to have infections. And it's so high, the prevalence of bacteriuria, that it increases with the presence of catheter, even 5% per day. We have to keep this in mind. So let's talk now about the older patients. They are very special, and we know that we are growing, the population is growing, and probably we have more and more older people in our societies. That's what's happening in Spain. Fortunately, we are the second openness of life around the world, just behind Japan. But probably in the next future, these figures to the right will be more common. And this is a concept that we came with older patients, immunosenescence. That means that these patients have alteration in barriers, have change in cellular and humoral immunity. That means changes in transduction of cytokine signals, and of course, poor response to vaccines, and of course, impaired immunoglobulin production. So that means that aging means a way to go to urinary tract infection. But how? Of course, for those menopausal women, hypoestrogenism is a mechanism that can lead to urinary tract infection. And this immunosenescence is very important in older patients that can lead to urinary tract infection. But with aging, we have more comorbidities, especially diabetes mellitus, neurogenic conditions that can lead to urinary retention and can lead to neurogenic conditions that led to these comorbidities that led to urinary tract infection. Of course, cognitive impairment is very common, and this means that this patient will have a low fluid intake, poor hygiene, and infrequent voiding that are prone to and led to urinary tract infection. Of course, especially in women, there is a pelvic floor muscular awakening leading to stress urinary incontinence or prolapse, and in men, benign prostatic enlargement that leads to obstruction or overactivity, finally leading to urinary retention or urinary incontinence and urinary tract infections. And of course, aging means frailty. And frailty means a higher risk of hospitalization and institutionalization. So that means that there is an increased risk of catheterization and exposure to resistant microorganisms and, of course, urinary tract infection. And if we look at this, all of these conditions, probably excluding pregnancy, all of these factors are common in older people. So we have to think in older people and urinary tract infection as a complicated urinary tract infection. Because symptoms in the elderly, of course, there are common symptoms and signs with urinary tract infection, but always most of the time they have general symptoms like confusion, disorientation, agitation, dizziness, falling, depression, anxiety, etc., etc. But these common signs and symptoms have a low positive predictive value. In fact, this is a nice study with a systematic review and meta-analysis of signs and symptoms of urinary tract infection in older patients, and found that these findings of nocturia, urgency, abnormal vital signs are of limited value. And of course, inability to perform the activities of daily living are predictors of UTI. And in men, especially incontinence, de novo incontinence of foul-smelling urine or hematuria are signs of urinary tract infection. And what about fever? Fever is absent nearly half of times. And we have to look at other factors that are especially important in older people. Because diagnosis UTI in old people is challenging because of cognitive impairment, with the high prevalence of LATs, we have been talking about that all of these days, and of course, the presence of asymptomatic bacteriuria that complicates the scenario. In fact, only urinary analysis have to be done if there is a classic signs of symptoms and symptoms of UTI or are signs of severe acute illness. If not, it's worthless. You have to think in older people about antibiotic management, some special characteristics, especially they have a special pharmacokinetics that we have to keep in mind. And there is an increased risk of multi-resistant microorganisms, especially if in nursing homes when they are hospitalized. And there is a decreased adherence to the treatment because of cognitive impairment or polypharmacy side effects and things like that. Let's move to the treatment now, and we have to keep in mind this asymptomatic bacteria. This is very prevalent. We know from the European guidelines that we don't have to treat asymptomatic bacteriuria, especially in postmenopausal women or elderly institutionalized patients. But when we have to perform any invasive procedure, it's important to treat. This is general for all people, and especially for elderly patients. What about those patients who are catheterized and have fever? 2 of 3 are attributed to urinary tract infection, but most of these fevers resolve in 24 hours without intervention. We have to keep this in mind. And what is obtained from a consensus panel of experts in urinary tract infection is that only if the fever prolongs for more than 24 hours or are rigorous or shaking chills or other delirium or general problems, in this case we have to prescribe antibiotics. If not, we have to wait. We have to check for other focus of fever and not to think always in the catheter region. Of course, replace or remove the treatment is what EAU guidelines say to us, and especially just to obtain a urinary culture in these cases. Of course, our nurses have to know how to maintain and just to have a good maintenance of the catheter just in order to prevent these infections. And just specifically the treatment in recurrent urinary tract infection, we have to think about the general behavioral therapy as well. The level of evidence, according to guidelines, is low, and well, the recommendation is weak because there is no direct relationship. But of course, we have some of our older patients that has a low fluid intake or the hygiene is not very good, and maybe these are actions that we can, of course, recommend. Probiotics, well, you can find any kind of studies in favor or against, and finally, no recommendation can be done with probiotics. Vaginal estrogen replacement, of course, is very interesting, especially for those women, menopausal state or elderly women, but especially vaginal. Natural, of course. And what about intravesical antibiotics? Well, those who are catheterized maybe obtain some benefit, but the results or the evidence is only limited to those with neurological conditions, so maybe an option, but it cannot be recommended. And this is the same for GAG's installation, bladder installation. There are 2 studies, one of them randomized to cotrimoxazole that shows some good results, but further investigation is needed and no recommendations can be done, especially we don't have any data on elderly patients. Vaccines, well, it has a high level of evidence and recommendation is high in the guidelines. Our experience in patients is good, especially in neurogenic patients. But in elderly patients, guidelines recommend it, but recognize that we don't have enough evidence in this kind of population. And of course, cranberries or D-mannose, we don't have enough data just to recommend. We need further studies. And we need especially studies in elderly people because we don't have in this specific population what's the evidence on that. About antibiotic prophylaxis, well, we know many years ago, from many years, and it's reflected in the guidelines, that it has a high level of evidence and recommendation is strong. But especially in older people, it's demonstrated that there are lower rates of clinical recurrence and antibiotic prescribing. And of course, especially in men, there is lower levels of hospitalization due to UTI. So, in concluding, my take-home messages from this recurrent urinary tract infection in the early. First of all, this is a growing problem. We have to keep in mind this, and we have to take care about this. Of course, we have to think about elderly as a complicated urinary tract infection, because many of them will end with a septicemia, and many of them can even die, and we have to keep in mind this. And of course, we have to have more insight in the next year about older patients, because many few studies have been developed, and as urologists, we have to know concepts from the geriatricians. We have to know about comorbidity, polypharmacy. We have to know the concept of frailty, and just to incorporate all of these concepts to our clinical daily practice. Thank you very much.